The next session, and I call chairpersons Dr. Amy Sangvi, consultant diabetologist and co-director Sangvi Eye Center, Mumbai, and Dr. Deepak Chudasma, consultant diabetologist, Hope Diabetes Center, Junagadh. Thank you.
Yes, good evening to all. Moving forward to our last session of day today, I am inviting Dr. Nandita Arun for next talk. She is consultant diabetologist in A. Ramchandra Diabetes Hospital, Chennai. She has various fellowship degrees from Glasgow and UK. She has been awarded with COVID Warrior in COVID pandemic. She is Diabetes Care Personality of the Year 2019, Outstanding Young Investigator Award, and also she received RSSDI Young Investigator Award as well. Above all, she is my teacher and PG guide. Over to you, ma'am. Thank you.
Thank you, Deepak, and thank you, Ami, for chairing the session. Yes, it's an absolute pleasure when you see, I wouldn't want to call you my student, but yeah, maybe if I could say so, chairing your own session. It's an absolute pleasure, really. So, very good evening, everyone, and I bring greetings from ARH Chennai. Of course, I would like to thank the organizers before I start for inviting me, and very happy to be part of Diabetes India 2022. The topic that I'm going to be discussing today is sort of an extension of what we've listened to in the last couple of sessions from Dr. Neeta, from Dr. Manoj, where they addressed inertia or clinical inertia in the management of diabetes, and that's what I'm going to be discussing further in general today, not just specifically for insulin, but in general as such. So I'm going to start off because at the end of the day, we're all here, we are all clinicians, and when we leave the hall today, I want us all to be able to apply this and take a carry home message to our clinics when we get back on Monday morning. So I want to start off with a clinical scenario. This is a Mrs. So-and-so who is 47-year-old, who is a homemaker, mother of 3 children, and she's been newly detected with type 2 diabetes. She's now sitting in the clinic with a HbA1c of 7.1, fasting of 128, postprandial of 189, and she has no comorbidities or complications at the moment in this consultation. So after discussion with the patient is hesitant, and this is very common, isn't it? How often do we find patients saying, no doctor, do I need to start off on medication now? Start medicines, will I have to take it lifelong? Isn't it? This is a question that most patients come up with. So this patient, not so uncommon, she was hesitant to start medication, and so she was advised with lifestyle modification only and advised to review after 3 months. But of course the story didn't end there. She comes back only 3 years later, and this time she comes with complaints of weight loss, and her HbA1c from around 7 that it was has now spiked up to 9.1, and at this point now she already has 2 complications, retinopathy and microalbuminuria has already set in. So what went wrong here? Was this absolutely avoidable, and who is responsible here? That's what we're going to be discussing here today. And this is exactly what is called therapeutic inertia. The definition of this is the failure to establish appropriate targets or to escalate therapy in order to achieve those targets. And therapeutic inertia is what is most of the time responsible for the complications which are most of the time preventable in patients with type 2 diabetes, with diabetes in general. And having said that, this is what brings us to the concept of the so-called glycemic burden. So here you see, don't know if my pointer is going to show up on the screen. Yes, it is, great. So typically, when we see the patient for the first time, we find the first HbA1c is below goal, and we are okay with that. In the next visit, the HbA1c subsequently then goes up, and then we don't act, take no action for whatever reason that might be. Next visit, it further goes up, and this is the story that's usually happening. And this over here, the threshold above which the HbA1c then spikes up is what is called the glycemic burden, which is what is responsible for our increased risk of complications in our patients. And this is typically what we find in our in probably most patient scenarios, where we have the so-called stepwise approach, where initially, just like the patient that we saw in our first case study, we initially advise the patient on just lifestyle management, and then we wait until the next visit till the HbA1c goes up, and then we add one agent. Then we wait until the HbA1c goes up, and then add the next agent. So every time we are actually reacting to a high blood glucose. Instead of being proactive, we each time wait for that HbA1c to go up, and then we take action. And in the meantime, the patient is being exposed to that amount of hyperglycemia and the so-called glycemic burden, which in turn is not going to give us very good outcomes. And we know that the best way to reduce the risk of complications, of course, these are the landmark trials. I don't need to dwell too much on this slide, but we do know the take-home messages from these slides are that trials like the UK-PDS, which is the landmark trial that showed us that, in fact, it is intensive glycemic control and early glycemic control that can reduce the risk of complications. We know that early intensive glycemic control will reduce the risk of microvascular complications, but when it came to the macrovascular complications, even trials like the ADVANCE, the ACCORD, and the VADT failed to show benefit in terms of macrovascular. However, the UK-PDS did show benefit in terms of macrovascular risk reduction only in the long-term post-trial follow-up, the so-called legacy effect, isn't it? Now, this legacy effect is what we learned from the UK-PDS. But in a publication by Dr. Kamlesh Kunti et al., this is what they have termed as dysglycemic legacy. So from the UK-PDS, we learned about the legacy effect. But here we are going, the legacy effect in terms of glycemic effect. But here we are going to talk about dysglycemic effect, or the dysglycemic legacy. So what is that? In this study, which was very interestingly conducted, what was done was patients who were newly detected with type 2 diabetes received intensification of therapy within the first 1 year, versus patients who did not receive intensification, in other words, did not maintain in the first 1 year HbA1c of less than 7%. So only for that first 1 year, the patients with intensive therapy versus non-intensive with less than 7% HbA1c. And at the end of 5 years, they actually found that there was a significant increase in cardiovascular outcome in the control arm, with a 67% increase in MI, 50% increase in stroke, 64% increase in heart failure. So high cardiovascular burden when treatment intensification is delayed in the first 1 year after diagnosis. Now, how is the burden of diabetes in our country? I have to touch upon a little bit of epidemiology here. Do we think, yes, we all know that we have explosions of type 2 diabetes in our country. We know that there are large growing numbers of patients with type 2 diabetes. But are the numbers still growing? The answer is yes, absolutely. So here we have data that from our center that we've been publishing right from the 1980s. And we've been going back serially almost every decade to look at the prevalence of type 2 diabetes, not just in the urban, but also in rural India. And as you can see, the arrow is actually going upwards and we have exploding numbers. What are we doing about this is the question, right? At the same time, the drugs for the management of type 2 diabetes, we can't complain because we are in an era where we have also an explosion of drugs. Look at the evolution of management of type 2 diabetes. So with the evolution, you first had insulin, which was discovered 100 years ago, and then there was sulfonylurea, and then there was a lull, a period where there was no other agent that was available until metformin came back in the 1990s. And then look at this spike in the number of agents that we have today. So we as clinicians treating patients with type 2 diabetes should not be complaining, especially in this era where we have at our disposal n number of agents to choose from, agents that are powerful to reduce the HbA1c, agents that are powerful to reduce the HbA1c without the risk of hypoglycemia, agents that offer benefit with not just reducing HbA1c, but beyond glycemic benefit in terms of reducing the risk of complications. The SGLT2 inhibitors, the GLP-1 receptor agonists. So we literally do not have anything to, no excuse to not be achieving targets. However, this is data from Gare et al., which shows that among the multidisciplinary approach that we have, or the ABC, that is the A1C, cholesterol and blood pressure, still, this is data from 2003, a long time ago, but where they showed that the target which is the most challenging to achieve is HbA1c. Among blood pressure, cholesterol, you can see almost 70% of patients, and this is true in our daily practice, we see this every day, isn't it? It's quite simple to control that cholesterol, quite simple to control the blood pressure, but somehow when it comes to blood glucose, it is very challenging. And let's look at data. This is global data. This is the percentage of patients who are not achieving targets, and it's quite, this is good news that we have here, that we are not doing that bad, so we should probably give ourselves, pat ourselves on our backs. Maybe conferences like this are really helping, where 50% of our patients are achieving a target less than 7%, compared to high numbers like 80% in Algeria, almost 80% in Saudi Arabia, 75% in Malaysia, patients who are not. So merely hardly around 20% of their patients and 50% of our patients. But what about that 50% who are not achieving targets, right? This is a very interesting publication in which our center was a part of, in which it was a global study where it was a multi-disciplinary, multi-center sort of model, in which what was looked at was the trend in prescriptions and trend in approach to type 2 diabetes management over the years. Is there a change in our trend of prescriptions over the years from 2006 versus 2015, over a decade? Because now we have so many agents, have our patterns of prescriptions also been changing? And this is the results of the study. And this is data that you have from India, which I've highlighted here. And if you look at comparing 2006 versus 2015 over a period of 10 years, yes, we are improving. If you see the red bars, there is an intensification in terms of increase in insulin therapy, and we are treating with more aggressive triple drug therapy as compared to 2005, and our monotherapy and diet only has actually come down. So we are actually trying our best as physicians to intensify. We are intensifying our approach, and in the bottom over here you see the change in HbA1c when we compare India to other countries like South Africa, where there has been from 2000 over a period of one decade, there's actually an increase in the HbA1c of patients with type 2 diabetes, whereas in India there's actually a significant reduction in HbA1c levels over a period of 10 years. And these are the patterns of prescriptions. So if you compared 2006 versus 2016, the percentage of of course, SGLT2 inhibitors were not available then, but 16% prescriptions of SGLT2 this is the percentage of increase. 20% with meglitinides, alpha glucosidase 22%, and 2.8% of GLP-1. So we are actually underutilizing the GLP-1 as compared to a whopping 10% in Australia. But compared to Hong Kong, we're doing much better. So we're prescribing GLP-1 receptor RAs quite well, I'd say. 40% of our patients are on DPP-4s, 77% of our patients on sulfonylurea, and metformin increase seems to have increased from 60% to around 90% of our patients are on metformin, which means that we're actually doing pretty well. So our patterns of prescriptions have changed, and we are definitely trying our best to intensify therapy, but is it good enough is the question. So where is the root of the problem? When it comes to therapeutic inertia, where is the problem actually? There are several reasons, and it can be either clinician related, patient related, or the healthcare system related. Clinician related the reasons would be insufficient time, isn't it? And just like Dr. Neeta was just saying, we are all so busy in our practice. We don't sometimes see the patient as another person, and when the patient is hesitant to start medication, we sometimes just dismiss it and say, because we need to see the next, we have a whole number of patients waiting outside, so we really don't have the time to spend that much, isn't it? The next is the patient hijacks clinical visits, and this is something similar to what we saw in our case study, where patients themselves are hesitant, and they sort of take over the consultation and say, doctor, don't worry, I will show you next time, isn't it? Next time I will bring down my HbA1c. Don't worry, doctor, leave it to me, I will take care. isn't it? It's because I had some weddings, I took some sweets, my granddaughter's, birthday party or whatever it is, there's always an excuse. So this could be one of the reasons, and many a times we also don't want to lose the patient. When it comes to treatment intensification, if we enforce and if we are forcing patients when they are not willing, sometimes the patient might just go to the next doctor, isn't it? So that itself is one of the reasons why many clinicians, I think, just don't want to be too harsh, or they're just the fear of losing the patient itself. And then, of course, the reactive instead of the proactive approach, which I already addressed. The patient-related reasons would be denial of the disease, lack of health literacy, medication-related, very, very important, where side effects of medication, too complex regimes where we give them multiple shots of insulin per day or multiple tablets, or the pill burden is too high, or costly medication in our part of the world especially. And last but not the least, and this is something that's very, very important, absence of symptoms. We must remember that diabetes, especially type 2 diabetes or hyperglycemia, can be asymptomatic, and we all know that. So for the patient sitting in front of us, taking that shot of insulin or taking that oral agent is not rewarding. When the patient has a headache, he's anyway going to take in that paracetamol, or if he has a tooth pain or whatever, or a stomach pain, he's going to take that tablet. Even for blood pressure, sometimes they're symptomatic and they say, oh, I have a headache, maybe my blood pressure is high, and they take in the tablet. But when it comes to anti-diabetic agents, taking their medication is not rewarding. So what keeps the patient motivated, chronic, for their entire lifetime to take their medication? Isn't it? This is something that we need to think about, and probably spend time explaining to our patients the importance of adherence to their prescriptions. And then, of course, the healthcare system could also be something that may be a reason for it, where we don't have supportive staff, we do not have patient educators, nurses, and so on. So the solutions to therapeutic inertia would be to have, as far as possible, to find solutions to those problems that I just discussed. Maybe try to spend more time with your patients. If you do not have the time, invest in a patient educator or a nurse, or just someone who can explain to your patients and spend some time clearing their doubts. For patients who have fear of injections, maybe improved devices. All these are various approaches, and a psychologist or basically an integrated approach that could actually help with overcoming therapeutic inertia. And last but not the least is, of course, apps and mobile technology, or the application of technology in diabetes. And there's a big boom, of course, we know. With all the apps, there's been some discussions even today in some of the sessions about mobile apps and their roles in improving patient outcomes. So we had actually, I'm just going to end with this last part of my talk, which is one of the studies that we had actually conducted to actually look at the role of improving adherence to prescriptions through simple mobile phone text messages. So patients who were newly detected with type 2 diabetes, around 250 patients, were randomized into two groups. Both the groups received standard of care, but only one group, the patients received serial text messages on their phone, just basically reminding the patient to adhere to their prescriptions and to take their medication regularly. Just simple text messages in the local language or in English, twice or thrice a week, to remind the patient. And at the end of the study, we found that there was a significant improvement in HbA1c in the intervention arm, that is the SMS arm, as compared to the control arm, and a significant improvement in the fasting plasma glucose in the intervention arm. So simple text messages on the mobile phones actually helped in improving patient adherence and in turn improving outcomes in these patients. So in summary, we do have a huge burden of type 2 diabetes, especially in our part of the world, and not just in the urban but also in the rural areas. And we have, in spite of so many newer agents that we have available, and in spite of our trends in prescriptions, we of course are trying our best to intensify therapy, but somehow we have to identify what is going wrong, identify where the inertia is actually existing. Think about the fact that the whole dysglycemic legacy is also equally important, and early intensive control is extremely crucial to reduce the risk of complications. Simple solutions like maybe having a patient educator, patient education programs, improved devices, and like I showed you, the role of technology also could go a long way in combating therapeutic inertia and thus improving outcomes in our patients. Thank you.
Thank you, Dr. Nandita, for such such a wonderful presentation. If we have any questions, we can take a couple of them for ma'am. Yeah.
Absolutely. Yes. Thank you for that comment.
Thank you, sir. Any more? Okay. Thank you, Dr. Nandita. Thank you for a wonderful presentation. Moving on to the next talk of this part of the symposium, mixed bag. I invite Dr. Om Lakhani, who is going to be taking us on the mechanism of beta cell dysfunction in type 2 diabetes. He's a well-known endocrinologist from Ahmedabad, the winner of the President NBA Gold Medal in Endocrinology, second runner-up in A.V. Gandhi Award 2017, winner of 2 gold medals in MD, winner of 5 gold medals in MBBS, winner of API Dr. Vittal Rao Nargowda for best thesis in MD Medicine, and the developer of the notes in endocrinology, and one of the most famous speakers we have around. I invite Dr. Om Lakhani to take over.
Thank you so much, ma'am, for the kind introduction, and sorry for the delay. I think the slides were taking a time to get loaded. Thank you to the organizers of Diabetes India for having me. Such a wonderful venue, and I think I'm sitting right in between, maybe an enjoyable dinner, maybe some fun. So I'm going to talk to you about mechanism of beta cell dysfunction in patients with type 2 diabetes mellitus. So, we always learn a lot from our animal models, right? And what have we learned from our animal model of diabetes? Let me take a step back. What's the difference between a pre-diabetic and a patient with type 2 diabetes? The difference really lies in the function of the beta cell, right? A pre-diabetic is perhaps as insulin resistant as a type 2 diabetic, but a type 2 diabetic, the beta cell does not function as well as a patient with pre-diabetes. So this is what we have learned from our animal models. So what they do when they create models for type 2 diabetes, animal models, they remove certain hypothalamic regions of these mice, and these mice are given unlimited food. So it's like this, right? There is unlimited food for you, and you have absolutely no satiety. So you can eat as much as you want. The mouse keeps gaining weight, and then what happens, right? The interesting thing is that the mice keep gaining weight, keep becoming more and more and more insulin resistant, but some mice develop diabetes, whereas others do not. Right? So what's the difference between a mice who develops diabetes versus a mice which does not? Well, the mice who develops diabetes has poor beta cell function. At some point of time, the beta cell function is not able to catch up with the insulin resistance, and that is type 2 diabetes. And that is exactly what happens in patients with type 2 diabetes in clinical practice. So, obesity increases insulin resistance, or any other factor increases insulin resistance, but if the insulin production is not able to match up with the insulin resistance, that is when diabetes develops. Let me put a corollary to you. There are a lot of patients who are obese, but they're not diabetic. And there are a lot of patients who are not obese, and yet they're diabetic, right? So if obesity alone or insulin resistance alone led to diabetes, every obese person should be diabetic, but that's not the case. Secondly, let me tell you another interesting thing, right? And we'll come to this point in a minute, right? So, this is a sort of a summary of how patients actually develop diabetes. And we know that insulin resistance keeps increasing but reaches a static point at a period of time. But what changes over a period of time is the beta cell function and the insulin levels. So initially, the body compensates by increasing the insulin production, but at some point of time, where you have the cutoff, where the patient stops, the beta cell stops working to the level it should, and that is when the downhill effect occurs, and that is when the patient develops diabetes, and then it continues to progress over a period of time. So at the time of diagnosis, 50% of the patient has lost 50% of the beta cell function, and they keep losing about 4 to 5% of the beta cell function every year. But the key question is, and this is the key point of today's discussion, and if you get this point, I think it's a job well done for me. The debate which is there in today's era of, as far as understanding of pathophysiology of diabetes is concerned, is that are we dealing with reduction of beta cell mass, or are we dealing with a reduction of beta cell function? This is the key question, right? Does the beta cell reduce in number, or does it become less functional? That's a key difference. Why this debate is important, right? There are arguments on debate on both the sides. You know, if you talk about beta cell mass, and this is another very interesting paradox that you see, there are a lot of patients who undergo pancreatectomy, right? Partial pancreatectomy. Some parts of pancreas have been removed, yet they do not develop diabetes, right? So beta cell mass has been surgically reduced, yet they do not develop diabetes. Yet there are patients who are obese, who have increased beta cell mass, but they have diabetes. So what the debate which is of the two, which is winning, the side which is winning is actually beta cell function. So more and more we are realizing that it is not just the beta cell mass which is resulting in diabetes, it is probably a dysfunction in beta cell which is the problem. And why this debate is important in today's era? In today's world, we are talking about diabetes remission. And when I say that the beta cell mass is reduced, that means it is somewhat permanent, right? Generally, you know, if the cells die, they're not going to be resurrected, right? Well, they might be, we'll see, but generally they're not. But if a beta cell stops functioning as well as it is, probably you can kick it and maybe it will start functioning better. So when I'm talking about a potentiality of diabetes remission, it is better to believe that beta cell function is the one which is causing diabetes and not the mass. And if the beta cell function can be restored, perhaps you can improve the outcome in diabetic patient. So this is why it is very, very important to understand the debate, that if I'm saying that the beta cell mass is lost, that is perhaps permanent, and that means that there is perhaps nothing like a diabetes remission in true sense. Whereas if the problem is in beta cell function, perhaps there is a potentiality of diabetes remission, and that is what, you know, recent trials like DIRECT trial has shown. So why does the beta cell impairment occur in type 2 diabetes? Why does it occur? That's the, you know, and that's the, key point of the talk today. What is the mechanism? What leads to the beta cell dysfunction? There are three key things, right? And this is a very interesting, taken from a very interesting article, which are the models for beta cell impairment or beta cell, dysfunction in patients with diabetes. So there are three major reasons. One is, of course, we discuss reduction in beta cell mass. We'll discuss this. The second key point, that is what, again, we are going to discuss, is the beta cell dysfunction. And the third and the emerging concept is that there is trans-differentiation of beta cells, right? Beta cells change into alpha cells or perhaps, other pancreatic cells, and that is also perhaps leading to a problem in these patients, right? Why this is important? Because today's talk, today's pathophysiology talk will perhaps be an option for treatment tomorrow, right? today's understanding of pathophysiology is tomorrow's treatment, and that is what is really important. So the first model which we talked about is the reduction in beta cell mass, and you know, what are the reasons for that? Now if you go back right from the beginning, there are a lot of people who say that people have, especially Indians, have, you know, low beta cell mass to begin with. That is fetal programming, you know, Barker's hypothesis, you know, Dr. Yajnik's things, right? The second is perhaps the beta cell undergoes apoptosis over a period of time, and perhaps aging itself leads to decrease in beta cell mass. So there is genuine reason that there could be reduction in beta cell, right, mass as well. You know about Barker's hypothesis. We know that, you know, perhaps there are epigenetic changes which occur in utero, and because of this there are certain genes which get switched off, and we are born unfortunately with a smaller beta cell mass that puts us at a risk of developing diabetes in future. The second model is the key one, which gives us a hope, right, that there are some factors which lead to damage or beta cell dysfunction, and there are two major reasons which have, you know, which causes this. One is what is known as endoplasmic reticulum stress, and second is what is known as oxidative stress. I'll discuss each of this. So what is endoplasmic reticular stress or ER stress? See, endoplasmic reticulum is given a task that it has to maintain a normal structure of the proteins, right? Now we know that protein is a primary, secondary, tertiary and a quaternary structure, and insulin is a very complex protein which has a very good quaternary structure, right? Now when a protein is formed, if this protein is not perfectly formed, the endoplasmic reticulum will, you know, destroy it. So when you have a lot of malformed protein accumulating into the endoplasmic reticulum, this produces a situation of ER stress. And in this situation, the cells take a critical decision. I have a lot of garbage in my neighborhood, right? Now there are two things I can do. Either I can clean my neighborhood or I can close it down. A lot of COVID cases in my neighborhood, either I can treat those COVID cases or I can, you know, put a shutdown, right, or lockdown. So in lot of times the body tries to respond by improving by cleaning the system. But in lot of times when it is going beyond that particular system, the cells start undergoing apoptosis. And this happens not only in pancreatic beta cells, it occurs in many, many cells of the body, and that is very, very important. Second is the oxidative stress and beta cell dysfunction. Where have we seen this? We see this in patients who are having glucotoxicity. We have all seen, you know, we see a patient who comes with blood sugar of 500. You start this patient on insulin, the blood sugar comes down, the patient's, you know, endogenous insulin production improves, the C-peptide improves. Why does it happen? This happens because there is a system in our body where you have a chronic hyperglycemic state. It leads to increased reactive oxygen species, which stuns the pancreatic beta cells. The beta cells are not able to produce more insulin. This produces a vicious cycle, right? When the beta cell are stunned, there is no insulin. Less insulin means more blood sugar means more reactive oxygen species, right? So when you break the system by giving insulin or by you know, intensive managing patient early on, you reduce the oxidative stress, improving the beta cell function. Again, this has very key importance in future in terms of pathogenic treatment. The third model is, of course, transdifferentiation of beta cells. Beta cells start behaving like alpha cells. There is change in the nature of beta cells. This is still an emerging area of pathogenesis. We do not understand that, but somewhere, perhaps 10 years from now, if we come back at Diabetes India conference, hopefully at the same venue, perhaps we'll have some drug which prevents the beta cells from converting to alpha cells and perhaps going back to beta cell function. So of all these three models, the most important model is actually the model 2, the beta cell dysfunction, because at this point of time, that is the one which we can really treat and we can really help. Okay, so we had this debate on function versus mass, and at this point of time, there is nothing much we can do about the poor beta cell mass, but we can do a lot about the beta cell function, and that is what really we are looking at in terms of emerging treatment. So what is the clinical importance of what we have learned today, right? So few things. One is we have all seen this variant of Indian diabetes patient known as Indian Flatbush variant, right? Dr. Sujit Jha, unfortunately passed away a few weeks back. With all due respect to him, there's a beautiful article written by him. It was published in Diabetes Care, where he identified patients where, which was first identified in Flatbush, which is a region in Brooklyn, right? These patients come with severe hyperglycemia, obese patients coming with severe hyperglycemia, and when you treat this patient, they come with ketosis. When you treat this patient with insulin, suddenly after a few weeks, the insulin requirement goes away, they go into remission, right? This is a classical example of oxidative stress causing beta cell dysfunction, which is reversible. Of course, we have the key point is diabetes prevention also. This is a very important point. This is an article by Ralph DiFronzo on why preservation of beta cell is key to diabetes prevention. I think this is more and more knowledge on this topic really has to be thing. And of course, we have Dr. Arvind Gupta. I saw him in the morning today. This very nice article published in API, which was beta cell preservation in type 2 diabetes, where they talk about the various strategies we can use to preserve the beta cell. These are some of the strategies: early intensive glycemic treatment, early initiation of insulin therapy, perhaps using of certain agents which have ability to preserve the beta cell, like your metformin or DPP4 inhibitors and so on. So again, one very important message, this is an area of debate. I don't want to get into the debate of this, but a lot of times, there has always been a suspicion that sulfonylureas perhaps hasten the process of beta cell dysfunction, right? Or perhaps lead to more permanent issues, right? Whereas other drugs do not. And this is a very old study, old sort of meta-analysis, where they looked at this article and they found that actually glyburide, led to, over a period of time, these patients on glyburide or sulfonylureas had poor beta cell reserve compared to those patients who were on metformin or rosiglitazone for that matter, right? And then we all have seen this short-term intensive insulin therapy. It has become less popular now, but you had, I remember reading articles of the senior Dr. Sahai on this, a very interesting area of short-term intensive insulin therapy. A patient comes to you, young patient, you start them on insulin, basal bolus insulin, and after a few weeks, the insulin requirement goes away. The patient then goes into remission and then maintains remission for a period of time. So what I'm trying to tell you is that all these are examples of beta cell dysfunction which are reversible, right? I think we need to recognize this important entity and perhaps help our patient in that way. So to summarize, and some important take-home message, first important message for all of us is that beta cell impairment, right, is the key to pathogenesis of type 2 diabetes. Please understand this. There are a lot of tech people I saw, I met a lot of them today. They're working on, exercise and lifestyle and all that. But you have to remember that there is a difference between a pre-diabetic patient and a diabetic patient. A pre-diabetic patient is insulin resistant. A diabetic patient, type 2 diabetes patient, is insulin resistant and having beta cell dysfunction. And this is very important, right? And this is where doctors continue to be important, right? The second important message is that insulin secretion is equal to, it's a function of beta cell mass and beta cell function, right? Of these, which is more important is an area of active debate, but as of now, we would really like to believe that it is a beta cell function which is more important. Perhaps that is why it is more in terms, the remission is more likely. And current thinking is more towards beta cell mass function than mass. Preservation of beta cell should be very important, right? It's a key important thing in pathogenesis of preventing or progression of pre-diabetes to diabetes, and also key in preventing the progression of diabetes in patients with pre-existing diabetes, right? So these are the take-home messages, right? We have this app, just for anybody who's interested in this topic. It's called Notes in Endocrinology app, right? So, we made some very good notes. It's a freely available app, right? And we made a, interesting app recently called the Centurion Insulin app. It's 100 years since insulin use. And this app is intended for doctors to really, see which patients are the right candidates for initiating insulin in type 2 diabetes patient, right? So it's again freely available. You can search on either your Android or your Google Play Store for Centurion Insulin app. It's freely available, and you can try putting some patients here. You'll see some good results, right? So thank you for a patient listening, and thank you once again to Diabetes India. Thank you.
Thank you, Dr. It was really a basic physiology, in-depth scientific learning session. Thank you so much. This is what we accept from you. Thank you.
Thank you so much. Thank you so much.
We'll move on to our next speaker, Dr. Vinod Mittal sir. Vinod Mittal sir, senior consultant diabetologist and head the Center of the Diabetes Metabolic Disease in Delhi. He is advisor and the past chairman of RSSDI Delhi chapter, fellow American College of Physicians, RSSDI Diabetes India and ICP, master class in diabetes management from RCP UK. Many honors and awards such as a National Award of Excellence in Diabetes Care and Dr. Sarita Bajaj Oralson in 2019. He is regularly invited as a speaker, principal investigator in several research project trials, national and international as well, and several publications in peer-reviewed journal and chapter in various books as well. Over to you, sir.
Very good evening, everyone. I convey my thanks to the organizers for inviting me to this esteemed annual conference, and thanks, Chairperson, for those kind words. I would be speaking basically on, it's a hot topic today. It's gliptin, gliflozin synergy. Almost every pharma company is now coming with a combination of DPP4 and SGLT2 inhibitor. So it's a kind of an ideal marriage, or ideal couple, we can say, DPP4 with SGLT2 inhibitor. We all know diabetes is a progressive disease, and there it is not only hypoglycemia which matters, but overall its other holistic approach has to be there. So blood pressure, lipids, and then weight management also is important. Now other important point is, now the approach is changing from glucocentric to basically protection or organ specific approach. And their heart and kidney, basically 2/3 of diabetic patients die of cardiovascular mortality, and now cardiovascular mortality is coming down because of good interventions. So kidney problem are going up, and both are going hand in hand. So one point which you all have to understand is, diabetic patients, if they have a CVD, you must investigate the patient for CKD, and if patient is having diabetic patient CKD or DKD, investigate the patient for CVD. So both go hand in hand, and generally one is missed. Now other important point is that South Asian phenotype is very typical. We are thin fat Indians, and there is increased insulin resistance in all of us, especially if you have central obesity and beta cell dysfunction we have just discussed by the last speaker. And there is a genetic predisposition. Almost a decade or two, Indians are having a diabetes prior to Caucasians, and then obviously lifestyle modification is important. So sedentary lifestyle and other inactivity is all other reasons. What are the unmet needs in diabetes? There is a recent study, in DAB study, and one more study which has shown only 30% of type 2 diabetic patients in India achieve A1C less than 7%. So this is an important point. Why 70% we are failing despite of so many anti-diabetic agents? Other is hypoglycemia. Even one single episode of hypoglycemia in a type 2 diabetic patient makes patient, the patient loses confidence, and patient generally they stop medication. That is why insulin is generally is the culprit, and patient generally avoids. One is pain and other is hypoglycemia. Then weight gain. Already we have 70% of diabetic patients who are having obesity. So, and there are certain agents like pioglitazone, sulfonylureas, and insulin, they also increase weight. So we have to see to these points, and then adverse effects of the anti-diabetic agents, and then last but not least the cost. Cost, convenience, and compliance. If an anti-diabetic agent is to be given twice or thrice, patient will avoid. There would be poor compliance and adherence. So all these points have to be taken into consideration when we write any anti-diabetic agent. So basically, our aims and objectives are, yes, definitely we have to bring down A1C to prevent complications, especially microvascular complications. For macrovascular, hypertension as well as dyslipidemia, obesity, and other factors also have to be, controlled. Now, as I mentioned, the approach has changed from glucocentric to a glucovascular metabolic, all three. So we have to get down A1C, no doubt. But at the same time, we have to avoid vascular complications and also correct metabolic abnormalities. So basically, there comes the role of agents which have a side cardio-renoprotective effects and metabolic benefits. So there, SGLT2 inhibitors, GLP-1, DPP4 are, the agents which are helpful. And obviously, we have to have an early and aggressive approach. We generally say early, it is never early. Even the day of diagnosis of diabetes, it is already late. Patient, the process started around 15 to 20 years prior. Action should have been taken around 20 years before the diagnosis. So it is never early. But still, when you diagnose, at least within 3 to 6 months, A1C should be brought down to less than 7%. Maximum is 6 months, and then it should remain less than 6 months, whole of life of the patient. Now this is the study, we can see here, like we can see in this study, HbA1c clinically diagnosed, it was 9.1 plus minus 2.3, very high. We come across such patients every day. And then diagnosed during screening, 8.3. So overall, average A1C of Indian adult diabetic population is 8.6, which is very high. And we are talking of bringing it to less than 7%. So generally, we treat to fail. There is a stepwise approach, one agent, 2 to 3 years, it is continued, then second, third, fourth. So basically we are treating to fail, and when we fail, then we add another agent. We never, say from, within 3 to 6 months, once it is controlled, the whole of life of the patient, it should remain less than 7%. Okay, so, we lose so many years, you can see. Insulin, almost 9 to 10 years delay is there in the initiation. And what to talk of, GLP-1 and other medications. And it has been very clearly shown in various studies that 1% of A1C reduction brings down, fatal and non-fatal MI by 14%, heart failure 16%, death from diabetes, like that is all-cause mortality 21%, and then, microvascular complication 34, even amputation and other, by 43. So just 1%. Average is 8.6. Even if we bring 8.6 to 7.6 per average, the Indian population, they can be so much benefit. Now, other important point is, it has again been seen that Indian patients, Southeast Asian, including Indian diabetic patients, the DPP4 enzyme levels are high. So we need to, that is why DPP4 inhibitors have been found to be more effective in Southeast Asians compared to Caucasians. So that's one point. So that makes DPP4 inhibitors as a good choice, and other is even SGLT2 inhibitors. So it is, more of SGLT2 inhibitors, to a lesser extent DPP4, both are more effective in Asian patients. So that makes, these two molecules to be used very early. Now, if we see gliflozins, that is SGLT2 inhibitors, basically effect is on kidney. And once, there is increased excretion of glucose in the urine, there is normalization of blood glucose, that improves indirectly beta cell sensitivity. And there is also, basically when there is an increased glucagon level, gliflozins, they decrease, early morning glucagon, but that is being compensated by gliptins. So don't bother about this small increase in glucagon which happens in the morning, and which is only for first few weeks. It doesn't continue for a long time. And then ultimately, there's loss of weight, systolic blood pressure, decreased uric acid, and obviously normalization of glucose. And gliptins, again, there's a dual pancreatic. Gliptins or GLP-1 are the only agents which have effect on suppression of glucagon, no other agent. That is why even the late stage of diabetes, they are effective. So once we combine these two, it becomes a kind of an ideal marriage, and we can address so many pathophysiological defects. So now the things have changed from prior to ominous octet. We all know that. I won't be going into detail, but important point is, once we combine SGLT2 inhibitors with DPP4 inhibitor, then almost 7 of 8 pathophysiological defects are being addressed, except the neurotransmitter, which again there are some studies where it has been shown that DPP4 inhibitors have some small improvement in even neurotransmitter. So that is, like even if we exclude that, 7 of 8 pathophysiological defects are being addressed once we combine SGLT2 inhibitors with DPP4 inhibitors. Now this is again important that, metformin sulfonylurea is the most commonly prescribed combination, and it is quite powerful and, good efficacy. Once we give metformin and DPP4, yes, it is again, quite powerful, less than maybe a sulfonylurea metformin, but low risk of hypoglycemia. So that's an added advantage. Once we combine all three, then we are achieving even a cardio-renal benefit, weight reduction, and systolic blood pressure reduction. So many advantages you can understand. Okay. So it is always good, and now even ADA 2022 guidelines also mention that patients, irrespective of baseline A1C, irrespective, it is not patients who are uncontrolled. Even if baseline A1C is 6.5 and a patient is having CVD, high risk, or CVD established disease, or risk for heart failure or diabetic kidney disease, give either GLP-1 or SGLT2 irrespective of A1C. You can reduce other agents because of their cardiorenal protective effects. Now, model of insulin resistance, if we see the HOMA assessment, model, there one thing is there, like as insulin resistance goes up, the beta cell function declines. So overall, higher the HOMA IR, lower is the HOMA beta function. So what we need to do is we have to decrease HOMA IR by some means, by reduction of weight. SGLT2 inhibitor is doing that. That will indirectly improve HOMA beta, so that is beta cell function would definitely improve. So overall, this is another important thing. SGLT2 inhibitors have been shown to decrease insulin resistance. We can see here an example with empagliflozin, and then beta cell function also improves with DPP4 inhibitors. So when we combine both, there is a reduction in insulin resistance and there's improvement in beta cell function, both the things. Yeah, so basically there is a complementary efficacy also. When both are given together, definitely efficacy will be much higher. And although when A1C is more than 8.5, the baseline, SGLT2 inhibitors perform better than DPP4. If it is less than 8.5, then DPP4 inhibitors perform better. But when it is higher, obviously, then we start with both the agents along with metformin. So despite of high efficacy, now sulfonylureas, we keep on increasing dose. We see, a prescription with 4 milligram glimepiride morning, evening. It is not required. We are just increasing the side effect hypoglycemia. Efficacy is not increasing. So 4 milligram onward, there is no increase in efficacy of sulfonylurea. We are just increasing the chances of hypoglycemia. But here when we are adding two molecules, there is no added increased hypoglycemic risk. Then other important point is SGLT2 inhibitors, they have an increased risk of genitourinary mycotic infection generally. And there is, the trials have shown that there is a reduction in GTIs with SGLT2 inhibitors if they are combined with DPP4 inhibitors. Probably the mycotic, the fungus which is causing this GTI, they are using DPP4 enzyme for their multiplication. And when we're giving DPP4 inhibitors, by inhibition of DPP4 enzyme, there is less multiplication. So there is less incidence of GTI when we're combining DPP4 with SGLT2 inhibitor. So overall, if we see, there is a better efficacy, more reduction, robust reduction, less polyuria and less infection, and same hypoglycemia. Now there are some studies which is again very important, Indians central obesity, and there's a less adiponectin. This is also has been seen, and here a study was done, and where it was effect on adipocytokines was observed, and we can see here that DPP4 inhibitors and SGLT2 inhibitors, they improve adiponectin levels, and there is reduction in retinal binding protein 4, fatty acid binding 4, and wisfatin, which are inflammatory cytokines. So those are indirect effect, so kind of pleiotropic effect besides glucose lowering. Now we have many studies with both SGLT2 inhibitors, so I won't be going into detail, but overall SGLT2 inhibitors have been found to reduce hospitalization due to heart failure, cardiovascular mortality, all-cause mortality. And similarly, we have studies with the DPP4 inhibitors, and DPP4 inhibitors are also found to be cardiovascular safe, except saxagliptin, which resulted in increased hospitalization due to heart failure. That's it. Otherwise, all, yes, vildagliptin and teneligliptin, we don't have any outcome study. So that point has to be kept in mind when we write these molecules. And as far as a combination of these two are concerned, we already have some combinations available. We have EMPA and LINA, we have DAPA and SEXA, and we have Remo Vilda. But again, with Remo and Vildagliptin, we don't have any CVOT trial. So that point, no evidence as of today. So this is only, and now since dapagliflozin is also generic, and times to come, even sitagliptin is going to be generic after July. So there would be more and more such molecules. The only message I would say that cost is important, but never compromise with quality in a way that all generics are not same, one point. Then you must see the PK/PD studies whenever a company comes, PK/PD profile of that generic molecule compared to innovator. So that's an important point, like we should not compromise on quality. So overall benefits of combining these two are that one is renal safety. Yes, DPP4 inhibitors, they reduce albuminuria. Cardiovascular safety, ease of use, very less side effects. SGLT2 inhibitors, cardio-renoprotective and metabolic. Reduction in systolic blood pressure, reduction in weight, and of that 70% weight loss is fat, and then decrease uric acid. So these are important, additional pleiotropic effects which sometimes become important. Even guidelines today, whether it is ADA, whether it is AACE, EAC, any guidelines you go, I think, for last so many years we've been talking, and I hear also maybe more than 10 speakers must have talked that SGLT2 inhibitor, GLP-1, GLP-1, the only problem is very costly. We have seen in the, I think the first speaker talked 2.7% only, are, and of those 2.7 also, within 3 to 6 months, there's a lot of attrition rate. They stop taking. Very few patients continue to take GLP-1 analog. So that is why in lieu of GLP-1 analog, we give DPP4 inhibitor. So that way SGLT2 and DPP4 become an ideal choice. So overall, this is my last but one slide. Overall, when we combine DPP4 and SGLT2 inhibitors, what we get is metabolic control, reduction in A1C of more than 1.8%, then other pleiotropic benefits, weight loss, decreased uric acid, blood pressure, cardioprotective effect, significant 3-point MACE, we have seen that, cardiovascular death, all cause and hospitalization due to heart failure, and then renoprotective. We already have DAPA, CKD, credence, and now in next month, ADA, even EMPA kidney, EMPA renal data also would be released. The top line results are already out. So basically, and that is even in non-diabetic patients. DAPA, CKD, EMPA kidney, non-diabetic also, the benefits are there. So overall, the takeaway messages are very clear that when we are, there is a clear-cut synergy between gliptin and gliflozin, and there is a robust A1C reduction, clear-cut, no added hypoglycemia, then weight loss, and most of it is fat, decreased systolic blood pressure, uric acid, and cardio-renoprotection, less genitourinary infection when you combining both, and overall, if we are having generics and of good quality compared to innovator, then obviously the cost, convenience if they're available in one tablet, and obviously they'll make more better compliance and adherence. So with this I conclude my talk and I convey my thanks to all of you.
Thank you very much, sir, for the wonderful presentation. I think we have a question for you, sir.
The combination of SGLT2 DPP4 inhibitor is very good. When we avoid sulfonylurea using alpha glucosidase inhibitor, DPP4, SGLT2 inhibitor plus insulin, we can avoid weight gain and many chances of hypoglycemia. So my preference is alpha glucosidase inhibitors, SGLT2 inhibitor, DPP4 plus biguanide. What is your opinion upon this?
So you're talking 3 molecules, AGIs with DPP4 with
Excepting
SGLT2?
alpha glucosidase, biguanides. If you can manage with these four, why not you sacrifice sulfonylurea?
First of all, any textbook on diabetology doesn't mention giving 4 medications before starting insulin. So it's generally 2 or 3 agents in there, some maximal, more than 50% of their maximum dose. And if A1C is more than 8 or 8.5%, this is the time to start insulin. That's one. So four drugs are not recommended, although yes, people are still prescribing. Now coming to acarbose like AGIs with metformin, they both cause gastrointestinal side effects. It will be added. Patients and in India, say if you're giving acarbose, it has to be given twice a day, sometimes even thrice a day, and even voglibose. So giving a medicine 3 times a day will make it, less compliant. Patient will not continue to take it. While DPP4 SGLT2 only once a day. Is that okay? And metformin AGIs is not a good combination. Not a good combination.
Metformin, AGLT, DPP4 plus insulin.
Yes, insulin if required later on. Yes, so metformin SGLT2 DPP4 insulin is a good combination. No doubt. Yes.
Leaving alone sulfonylurea.
Yes, definitely. Sulfonylureas are to be discontinued when you start insulin, especially prandial insulin. When you starting basal, you can continue sulfonylurea, but when you starting prandial, you must stop sulfonylurea.
I don't think we have any more questions. Thank you very much, sir, for the wonderful presentation, and thank you everyone for being here till this part of the day. See you all on the other side of the break at the dinner, and tomorrow morning for much more better science to be learned. Thank you.
Thank you.